primary care. We have some broad markers, maybe a compass direction of maybe where to head, but it's still early days. The reason why you're in the room, we're all stakeholders in trying to figure out what is the right path. I'm really excited about this panel because this panel has some really practical lessons that'll guide the way, that'll give us a little bit of a compass direction on where we should be going. Our plan for this session, you have to imagine a QR code up with a Mentimeter to have you engage before we get going. Now that has a technology problem, unfortunately, but we really want this to be an engaging session. And so we're going to have some key questions, we're going to speak a little bit, but we want to have plenty of time to make this a dialogue. And also I'll bring you in a little insight on what we talked about as panelists. This is not one of them where we have our papers and canned questions and they've been prepped. This is a dialogue that we are all going to have together that you're going to benefit from, and we hope at the end that you'll join us. Okay, so that's the spirit behind this. Let me turn it over. So we'll start with a round of introductions first and just share about the people that are here and their organizations and what they're doing around AI a little bit. So let's start with Dr. Rob.
Hi, everyone. Great to see a lot of familiar faces in the audience and even up on the stage. My name is Rob. I'm a primary care physician. I'm the Chief Medical Officer of Penda Health. I've been living and working here in Nairobi for the last 12 years. And at Penda Health, we run outpatient clinics. So we have 18 facilities across Nairobi. They're all open 24 hours a day, 7 days a week, 365 days a year. And we treat everyone from children who need vaccines or get sick to older adults with chronic illness. And then we've done a lot of work in the kind of digital system space, which recently has been AI, to try to improve quality of care and access.
Rob, give us a sense of the size, though, of Penda. How many clinics and how many your reach, just for scale?
We have 18 facilities. We've seen about a little more than 2.6 million visits over the last 12 years. And on like a daily basis, we see somewhere between like 1,200 and 1,500 patients every day.
Thanks, Rob. Let's move to Yvonne from AMREF. AMREF is a leading partner in primary care in Kenya and around Africa, and we're great to have Yvonne with us, who will share some of their work. But Yvonne, an intro into yourself and AMREF first.
Yeah, thank you so much, and it's exciting to have this conversation. My name is Yvonne Opanga. I work as the Learning and Impact Technical Advisor at AMREF Health Africa. And within our organization, the core of the work we do is primary healthcare, especially working with communities to ensure access to care and supporting the government in delivering primary healthcare model. My main role, especially in the context of digital health and AI, is to support our staff to pilot AI models, especially at community level, strengthening community health systems, and also looking at work around predictive modeling for diseases to ensure precise public health. Thank you.
Okay, and the same to you, Yvonne. Give us some scale size of AMREF. For people that may not know AMREF, what kind of scale do you do with AMREF Kenya, for example, of reach?
Yeah, so AMREF is actually an organization that is headquartered, international NGO that is headquartered in Kenya. So we are in more than 43 countries, both within Africa and across the globe. Yeah.
Thank you. Thanks. Next up is Joanne Peter from Japago. Japago also is a major player in primary care, if you know, on the continent, and we're great to have Joanne join us. So Joanne, give us a bit of an intro.
Try again? Oh, there we go. Yeah? Okay, excellent. Hi, everyone. Joanne Peter. So I am the Director of Innovation at Japago. For those of you who don't know Japago, we're also an international nonprofit organization working in global health, around 36 country offices. More than 20 of those are in Africa. And if you can't tell, I'm from South Africa. Very happy to be here. But so we also at Japago are lead implementer, along with Vilgro Africa, of a program called Health Tech Hub Africa, which is a Pan-African accelerator program that works with African health tech startups from across the continent. Since it began in 2022, it's worked with 118 different companies. And it also works with governments with policymakers, so ministries of health, ministries of ICT. We run an intergovernmental working group with, at the moment, representatives from 20 countries. And I see Dr. Ayub Mania sitting here, who's one of our wonderful IWG representatives from Kenya. So yes, wearing two hats today, JPIGO and also Health Tech Hub Africa.
Thanks, Joanne. Welcome. We'll start today by talking a little bit about what each group is seeing now in the area of AI, where they see it playing a part currently, and then eventually we'll obviously get to the future and where we're seeing. But let's talk about currently. Maybe I'll just jump in a little bit about HTHA and Vilgro that we're seeing very excited. Most applications that we see coming in, upwards of 1,000 a year, have some degree of acceptance of AI. It is here, it is happening, it's being embraced. It is not a sidecar, it is almost the main car. It is core of what a lot of applications are doing. But being still in healthcare largely unregulated and with data protection being so, there are some laws out there, but admittedly, they might be hard to follow. We're seeing, it's a bit of a, the term I'll use, a Wild West. There are a lot of people doing things, but it's not as maybe coordinated as it could be. I spoke to a lot of our founders prepping for this session, and it's exceedingly clear that investment in AI is going to only grow. Every founder and CEO I spoke to is just really dialed in on how they can leverage AI, what it means. No one's figured it out. There's a lot of scoping going on, a lot of exploration, a lot of partnership, sort of expansion, or seeing who can play a part. But it's certainly bullish, and it's certainly going in that direction. So that's a little bit of what we're seeing in current environment. But let's go to Yvonne next. At AMREF, what do you see with currently happening around AI in your AMREF universe?
Yeah, thank you so much. So I think there has been a lot of interesting trends that you're currently seeing, but mainly looking at the work that we do around supporting, communities through primary health care. We note that whenever you come up with a model, then it has to be corresponding to, a primary health care need. And in sub-Saharan Africa, I think there's quite a lot of gaps still remaining. You're seeing maternal mortalities still remain high, issues around data and fragmented health systems. And so that sort of siloed approach sometimes becomes a barrier, especially when you're looking at developing AI solutions. We still have gaps around diagnostics and also issues around the supply chain. So that's what we are seeing as the gaps. However, if you look at the past 1 year, there has been a lot of upcoming AI solutions. At AMREF, we run the AMREF Ethics and Scientific Committee. And in that committee, we review protocols. And you're seeing a lot of work coming up, of people coming up with AI agents to support, pregnant women, support community health promoters, and also support systems, especially in facilities, strengthening, facility EMR systems, and also supporting in clinical decision making. And so at AMREF Health Africa, what we're currently working on, since our work is centered around community health, we are working on an AI solution to support community health work. And what we've developed is a reporting assistant, an AI reporting assistant that supports community health assistance. So if you look at the health structure within Kenya, at community level, we have what we call the community health strategy. And this is often led by community health promoters. We already have supported the national government to digitize the process such that all community health promoters now have access to mobile phones, and the information that they generate is fed into the electronic community health information system. So what has been the problem is we have quite a lot of data that we've generated. But in terms of tracking performance of community health promoters, there has been a gap with their supervisors, who we call the community health assistants, the CHAs. And so the reporting AI solution that we've developed is anchored within the ICHIS data system. And what it does is to, one, support in performance management. Usually, community health promoters report on a monthly basis, and the reporting assistant is able to flag which community health promoters have not, input their data in terms of their performance, which households they've not seen. And also it's supposed to flag out, just looking at the different trends. Where are we seeing more malaria cases? Where are we seeing more cholera cases? So that we identify hotspots and then come up with, timely interventions to support that. In addition, the solution also has an interactive chatbot where, once the information is flagged, then it's directed to the community health promoter, and that really helps to follow and track CHPs. So we've seen that work well. We've piloted in one sub-county, that is Machakos, and now we are having conversations around scale. But one of the issues that is coming up that I think we may need to have a discussion around or think through is around the quality of data that is being collected. Garbage in, usually they say garbage in, garbage out. And the AI model you create is as good as the data that you feed it. How you train the model depends on the data. And so there has to be a lot of efforts to ensure that the data that is fed into the system, again, is of high quality. And then in terms of working together with the government and also strategic partnerships that have been key, because if you develop a solution, the next question is around scaling it up. So mostly working towards supporting the government to deliver has been the core of what we do. And now in terms of scaling, it becomes very easier for the government to pick up, especially if you engage them right at the beginning. And we want to stop there.
Yeah, no, thanks, Yvonne. That's fantastic. I want to move to Joanne next. I know that JPAGO has a growing focus on AI, and also the Health Tech Hub has a program that we've been supporting that might be interesting for the audience as well to learn about how we're supporting these AI innovators with our frameworks. But yeah, let me turn it over to you.
Now, it just needs an off and on every time, that old tech fix. We have this ecosystem vantage point at Health Tech Hub Africa. So I can share a little bit of what's been happening in the ecosystem in just like the last 2 years or so, which is quite amazing, really. It shows some of the momentum. So I'm sure you're aware of a lot of the increasing investment in AI that's been happening. So you probably have heard about the Gates AI scaling hubs. Started in Rwanda. The next one's in Nigeria, Kenya, and Senegal to follow. So those are investments. There's also FCDO in Ethiopia, and there's a Google AI Community Center in Accra. So there's a lot of investment that's coming in the ecosystem. And GSMA actually just announced another new major African AI language model initiative. So a lot of new players coming in. Cloud and compute is increasing, so more than 140 data centers now across Africa. Last year there was a big announcement by Microsoft, around a $1 billion investment in a data center campus here in Kenya. So that problem is getting solved, we hope, faster. We'll switch up. Thank you. Okay. On the policy front, African Union has been putting in place a number of policy frameworks, and we also are seeing national level policies that are coming through from a number of the governments that we work with. And then just in terms of sizing the market, so the projected growth is from about $4.5 billion in Africa now to about $16.5 billion in Africa, a lot of that driven by healthcare by 2030. So the market size is growing. And if you actually look at some of these calls that have gone out recently, so GSMA issued an impactful AI call earlier this year. They got more than 600 applications from 40 countries. 2/3 of those were from Africa. 20% of those were in healthcare. So a lot of the momentum is coming from Africa, and it's coming from healthcare, and there's a lot of increasing investment that's happening. Yeah, so that's some of the ecosystem stuff. Then I can just tell you about a couple of the use cases, yeah?
Please.
So thanks, Yvonne. You mentioned some of them. These are some of the ones that we've been working in at JPAGO. So certainly diagnostics and screening. So we're seeing a lot in terms of TB diagnostics, cervical cancer, breast cancer. So there's a lot of diagnostics and screening that's being supported through AI. risk prediction and segmentation. So prediction of, for example, defaulting on antiretroviral medications, or of pregnancy complications, or of missed immunizations. So there's a lot of models that are doing that kind of risk segmentation. Health worker training, clinical decision support, I'll leave that to you. You're going to talk about that in a moment. But yes, especially with large language models, more and more of that happening now. And client engagement, of course. So counseling and triage, that's happening. And then system optimization. So this is now about fraud detection. It's about supply chain forecasting, you mentioned, about better distribution of vaccines. So these are all kind of primary healthcare relevant use cases that we're seeing and that Jhpigo's been working in. I would only say that there's a ton of research happening, but to your point, Rob, a lot of it is still not integrated into the system in a meaningful way yet. It's still pretty nascent. And so it's preparing systems to really absorb all of these opportunities. That's the next frontier.
Thank you. Thanks. And thanks for the tee up to Rob here. The Penda Health has been on the front end of some of this AI integration, especially around clinician support. And so, Rob, we would love to benefit from your learnings, share what you've done and maybe what you've learned, because I think this is quite novel. Over to you.
Yeah, so I think one thing that I would love for everyone to kind of understand is for an organization like Penda, which is quite in the weeds, we're very operational, we're seeing lots of patients. I have both the privilege and the burden of seeing all of the mistakes that we make. I see the errors and the bad outcomes. Those all come to my desk. And there's so many times where you can very easily imagine if we had had an AI looking at this and supporting the clinician, would this patient have had a better outcome? And I think it's around the 3rd anniversary of ChatGPT's release. And we're so inundated by it that we can almost become immune to it. But sometimes you have to remember, these technologies are kind of magical. I mean, it's amazing what they can produce. Now, they still have problems, but if you kind of hold the fact that in the real world, we still have all of these kind of basic errors, and then the AI models are so capable over here. What we said is, how can we bring these into the workflow and have them actually improving outcomes for patients? And so that's what we've really worked on. We did a lot of work to bring them into the electronic health record, directly into the clinician workflow, always having a human in the loop. And then we ran 2 of really the world's largest studies. I think probably the most robust evidence of the benefits of AI in primary healthcare are coming from data right here in Kenya. And that was one study that we did with OpenAI that was about 40,000 patients, and then another study that was funded by PATH and the Gates Foundation that was about 10,000 patients. That was a formal RCT. And both of these studies were wildly successful in terms of how much benefit there was for patient care, appropriate diagnosis, appropriate treatment, better histories and physical exams, more appropriate use of diagnostic testing. Across the board, clinically and statistically significant benefits for clinicians who are supported by AI tools. So I feel really wildly optimistic about the role that AI can play to improve quality of care. I think it needs to be done in a very thoughtful way. I think we need to make sure that clinicians are at the center of this and that we're bringing it into the workflow in the right ways. But I think we should all feel really excited about the possibility of dramatically reducing errors and improving quality for patients.
Rob, is there some stat you can leave us with? Is there a certain number? I'm sure there were stats, obviously, with the trial, that you just throw us a nugget of something that was improved or something that really validated that this was the right direction.
Yeah, I'll give you 2. One is that we had about a 16% reduction in diagnosis errors and a 13% reduction in treatment errors. And that can kind of be like, okay, well, what does that really mean? The other number that's important is how many errors can be averted. Within Penda alone, in a 1-year period, it's about 50,000 errors. And why is that? Because it's not just one vertical. It's not like we're just doing this in hypertension, or we're just doing this for preeclampsia. This is a system that's functioning across every different type of patient visit, whether it's hypertension or a boda-boda accident. We can get this benefit across this huge range, and that's one of the beautifully powerful things about large language models is that they can just deal with all of the breadth.
Thank you. Thanks. The next piece, last evening had a conversation with somebody, and I love your optimism around Africa, because I share it a lot. There was someone saying, yeah, but we don't have the GPUs yet. From where I sit, first in 1990, but living here for 25 years, AI and Africa can play in the AI space much quicker and better than they could on earlier technologies. The adequate training is here, the awareness is here, the data is here, the vision is here, and how it can be used. Yes, we may not have the GPUs yet on site, but we can play in a way that is meaningful and impactful. And so I share that sort of optimism. Go ahead, Joanne. Yeah, please.
I just wanted to chime in with some of our experience around how important it is to think about then so what? How does this fit into clinical management? How does it actually affect health outcomes and clinical management? So we've also been involved in a large trial with Palindrome data. I don't know if there's anyone from Palindrome in the room. I know they have a session after this, so if you're interested, go and catch that. In Nigeria, it was around risk prediction for interruption in treatment, HIV-positive patients on antiretrovirals. And so this trial looked at around 50,000 patients. And what was important was that, of course, first you had to build the model and make sure that the model worked. But then after that, it was, okay, so now what? First of all, you've got to get it in the hands of health workers, right? So they need to be using this model. And so we had a case management app that was being deployed to case managers in Nigeria. And so it was possible to build in this risk scoring tool into the case management app that they were already using. But then what do they do if someone's high risk? What must they do with that information now? So there used to be 27 different interventions that case managers in Nigeria were able to deploy. And they were just an unstructured list of interventions. It was anything from like a peer buddy to help you to stay adherent to your medication, to counseling around the importance of disclosure, to maybe multi-month dispensing. But as a case manager, you didn't get any guidance on what to choose, and so case managers would just sort of use their favorite interventions. So what was important was actually starting to structure this, to risk stratify this list of interventions and start to say, these are the ones that are going to work best for the higher risk patients, and these ones for those that are lower risk, so that the model translates into something actionable at the front line for those health workers. And so what they found was that they started to spend about 76% more time on the high-risk clients, actually thinking about what to do with them. And then the result from that trial was that there was a 4 times reduction in interruption in treatment amongst the enrolled patients versus the control. That was 18,000 patients. So also a real result. But with a lot of learning around how to actually get health workers to engage with the tool. And let me tell you, they needed training and they needed retraining. It was not just an obvious adoption. And they needed to feel that they could override the recommendation if it didn't align with what they were seeing. That they had the ability to override and say, no, in fact, this person is not high risk. And the acceptability went way up when they felt that they could be that human in the loop and that they could influence the model.
Thanks. Yvonne, what excites you in this spirit of optimism here? And, is there something at AMREF that you at AMREF are seeing that excites you, maybe the low-hanging fruit, to use that term, where you see AI can definitely be leveraged, or you'd want it to be leveraged?
Yeah, so what has been exciting, and allow me to share an example of the work that we've done around, predicting acute malnutrition in communities. So this is work that has been supported by University of Southern California together with Microsoft. And there's power actually in predictive analytics. So what we did is we picked data that we have in KHIS with different, nutrition indicators, and also used satellite data just to look at, is there a possibility that we can predict acute malnutrition in the country, and how will that look like? And the goal for this was to solve the problem around, early interventions and also resource allocation towards addressing acute malnutrition. So what we were able to develop was a model that can predict acute malnutrition within a period of 1 month, 6 months, and also 3 months. 1 month, 3 months, and 6 months. And this has been a useful tool for the government in the sense that in areas where, especially the arid and semi-arid regions that we have, we are able to detect the occurrence of malnutrition 1 month early, 3 months earlier, and 6 months. And this is actually supporting county governments to adequately, allocate resources and also put in timely intervention to address issues of acute malnutrition. But what we learned from the process is, number one, we have lots of data that we collect that we can start utilizing, especially, what Rob is doing with the EMR systems and what we did with the KHIS system. But then the key question again is, how do we ensure that whatever models that we are developing, let me just say that a model is as good and relevant as the problem that is solving. You may come up with a model, but if it's not addressing a core issue, then it becomes, null and void. And so the next component is around working together with the government to co-design and co-develop some of these models. And that has really worked for us, especially utilizing the infrastructure that we have. The second bit that is quite exciting is the power of partnerships. I think for us, working together with different partners who are bringing in different expertise, different resources, has been, quite useful for us in that sense. Yeah.
Thank you. Just want to confirm to the admin team, we have a big clock up here, and so they granted us more time. Do I get oh, thank you. I was wondering how we're going to pack all this into such a short. Okay, so save your questions. It's coming. So we want to have a robust Q&A period. Just want to talk now a little bit about maybe where it's going, to the theme of what we talked about. Again, I think we have a bit of a compass direction, but not a Google map of turn left here to get to the destination. But love to share a little bit of what excites you about where we're going and what do you envision. And let's start with Rob here. Now we're hearing what we've heard already. Where do we see it going?
Yeah. So to me, one of the biggest barriers that we have, at least within Kenya, is that we need more digitization of healthcare processes. The only reason Pendo is kind of in this unique position to be able to even do these studies is because we've been totally paperless for 5 years. And that is a prerequisite to getting any of these benefits. You have to have all of the bio data. You have to have the vital signs. You have to have the history and the physical and the lab orders and the lab results. All of that stuff has to be in one place and right in a workflow that's digitized 100% of the time. That's really hard to do. It's really expensive to do. There's a lot of infrastructure to maintain. So how are we going to get to the level of scale of that digital infrastructure that lets us get to these benefits that we've now, I think, started to prove are there? And so my maybe hot take, maybe not too spicy take, is I think voice is going to be really important for this, because training thousands and thousands of people on how to use an EMR and how to use the drop downs and type into the right things is going to be a very monumental task. If we can have voice models that understand our local languages, that integrate well with the systems that we use, it's going to allow us to leapfrog again. There's so many examples of leapfrogging in Kenya, from landlines and M-Pesa and all of these things. Maybe the next big leapfrog for us is, can we use voice directly into more of a healthcare database and kind of skip the very heavy EMR implementations that we'd otherwise have to do?
Thank you, fascinating. Joanne, I see you wanting to jump in there.
Yeah, and I'm not the expert on this. I'm wondering if there's anyone from C4IR in Rwanda in the room. Don't see any hands. So I've just listened to a talk that they gave where they spoke about how they were trialing having the listening as the community health worker consultation was happening, and then automating the record keeping and the advice on the basis of listening to that conversation, which I thought was really fascinating because it takes away all of the routine data collection that currently is happening. But also, I wondered what the acceptability of that was going to be, because I knew if I was sitting in my doctor's consultation and I knew that the AI was listening and recording everything, and I would maybe feel a little bit nervous about that. But I did think this is a real leapfrogging opportunity, exactly as you said, Rob.
Yvonne, over to you.
Yes.
What excites you? Where do you see it going in sort of medium term, short, medium?
Yeah. So maybe before I respond to that, just what Rob mentioned, I think it's quite exciting to see the fact that now you're trying to integrate voice. But then if you look at the sub-Saharan African context, language, we have quite a lot of different languages. And the key question is, how do we crack that to ensure that whatever models we are creating then can also be translated into local languages for them to be useful. Remember, as we come up with solutions, we're trying to be people-centric. So if you come up with a solution and people cannot understand it, then it becomes quite an issue. So that's an area to probably, further explore. But in terms of how the future looks like, I think as Africa, looking at our context, we need to start thinking of, building models that are people-centric, first of all. Secondly, looking at, models that are transparent and can be replicable, so that then as we think about scale, how do you ensure that it's utilized across different African contexts? And then transformative AI. There has to be a solution that you're resolving that is relevant, number one, to the government priorities, because all the work that we do is to support the government deliver on primary healthcare. And so we also need to bring that in. But even as we also think about these models, we need to think about, are our models, exacerbating the inequality gap, or are they reducing? You may come up with a model and you have areas where still the infrastructure is low, people don't have access to bundles, etc. How is that solution going to be contextualized to be used in such context? And so the solutions we come up with should be solutions that, are context specific and factor in some of the, barriers and challenges that we do experience within communities. Then it's very important we think about responsible and ethical AI as we develop our models. What we've done in AMREF is, before you think of a model, what we do is co-create. And I had that conversation earlier today. It's important to co-create with the different users, different stakeholders, so that then you understand what issue are you going to address. And then the second bit, put in contextual factors. Do a pilot or a feasibility study to understand what are some of the facilitating factors. What will be the barriers to ensure that this model is put to scale. And then, of course, the last bit is to pilot it and then roll out. But then as you think of scaling, what we've also learned is the costs that come to scale. Who is going to bear those costs? And how do the costs, look like? And so the power of partnerships is very key, and the power of working within a system where you already have some resources that you can tap into. So how I see the future is, AI is providing solutions. Some of us have fears that it's going to take our jobs. It's not going to take that, but it's going to empower healthcare workers. Secondly, we need to start thinking of data integration, and I know Rob pointed that out. We're still operating as silos. And if you look at the primary healthcare context, we have health systems, but we also have social determinants of health, things like climate change coming up, livelihoods. And so different ministries need to start thinking of how do you work together to bring together a repository that can provide an environment for us to run analytics. So that sort of collaboration, multi-sectoral collaboration, I think it will be very key. So I'm looking at a future where we have, integrated, interoperable systems that have multi-dimensional set of data to support us, drive this agenda.
Thank you. Thanks, Yvonne. Very insightful. Joanne, over to you. Where do you see it going? Short, medium term? What excites you?
Well, big picture, I think, often say for Africa, we have 24% of the global disease burden, 3% of the health workforce, and 1% of the health financing. So, if you think about those numbers, something's got to give, right? You cannot provide universal health coverage, primary health care, in the face of those numbers, if you're going to keep doing things the way you've always been doing them. It just doesn't add up. So the status quo is not going to work. Building more brick and mortar health posts is not going to work. Training more health workers is not going to work. So something's got to be different, and this to me does seem to be the best opportunity we have right now to shake up the status quo and try to change that picture. So I don't always know exactly how we're going to do it, but I know we've got to do it. So that's point one. I do think you spoke a little bit, Yvonne, about partnerships. You also spoke about costs. I want to pick up there. I believe that we're going to need a lot of public-private partnerships, that a lot of these solutions are coming out of the private sector. We're seeing so much of this innovation coming through Health Tech Hub Africa in these amazing health tech companies that are emerging from across the continent. So I believe that a lot of the innovation and solutions are going to come from the private sector. However, they need to figure out how to work in the public sector. And that is one of the major challenges that we've been working to try to address, is how to allow private sector innovators to work in the public sector. And a big part of that is how they can actually be paid. So how can they be procured by the public sector for the services that they provide? How are those services priced? What is the payment model around them? And are public procurement processes designed to enable purchasing of these solutions? What does the business model look like, and how does that payment happen? And so that's one of the challenges that as Health Tech Hub Africa, we are trying to wrap our head around, bringing together a lot of smart people to think about this, because most public procurement was not designed for software, and it certainly was not designed for AI. It was designed for hospital beds and for vaccines and for physical health products that have a per unit pricing. And we just don't know how to do it well for these kinds of solutions. And so I think those 2 points, public-private partnerships and figuring out business models and payment models and how we can get private sector to be able to contribute to public sector, these are important things we need to be thinking about.
Thank you. Thank you. I think the learnings here are rich already. Questions are in a minute and a half. We're going to open up for 15 minutes of questions. To dovetail on what Joanne and Yvonne said, I think it's a super exciting time if you're an AI developer in Africa, because what we see is that there's been a dramatic increase in interest, even from the public sector, for innovations. The funding landscape, as we all know, radically has changed. And from a Vilgro standpoint, and maybe an HTHA, we see that as very positive, because there's a renewed, deep interest for those in our pipeline saying, what are they doing in health innovation? What's happening out there? Where before, not that they weren't doing it, but the interest might have been low. What we're seeing now, the funding landscape has changed. Not only is AI new, we're seeing a renewed interest because the funding landscape has changed. And so it's great if you're an AI developer on the continent, from my perspective. Guys, in 30 seconds, before we open to a Q&A, any kind of thought you want to share? Go ahead, Yvonne.
Yeah, maybe just to pick up from what Joanne said, as you think about scaling and coming up with business models, the other angle to look at it is also around the regulatory space that we have within our health ecosystem. Is it, supporting, AI models that are coming up? And I'm looking at young entrepreneurs that really have very good, vibrant ideas, but sometimes they struggle to get these ideas to scale within the market. Yes. And so that's an area that we may want to think of, looking at the current regulations and how we can make them enabling to ensure that then, the models that come up eventually and are being utilized.
Guys, we're going to stand by our promise of 15 minutes for Q&A. If you don't use it, then we'll keep talking. But let's open it up. You can tell we're passionate about it, and I see a lot of questions. Great. Guys, how are you going to hand around mics? So why don't you choose for us who the young man there, who the people are?
Did you get the dead mic? I think you got the broken mic.
Is it working now? Yeah. So 2 questions, if you don't mind. One is, you mentioned health outcomes. So how do we make sure that the tools we design are actually evaluated based on health outcomes rather than, performative efficiency metrics that I think AI is kind of intrinsically built to push? And then the second question is, so what I see in my work is that we often design tools that look amazing in controlled pilots. But then when we introduce them, they fail because they just don't fit in the workflows. So how do we design, what are some of the design principles except training and involving clinicians to design the tools that they will actually use?
Fantastic questions to start. Who wants to jump?
Do you want me to go?
Yeah, maybe I can talk about the outcomes question, which is a really good one. I think it's a general problem in health services that we tend to focus much more on process metrics rather than outcome metrics. So did a person with high blood pressure get their blood pressure measured? Did they get the right medicine? Rather than did this cohort of people achieve a lowering of blood pressure? And I think I don't have a silver bullet for that or an easy way to solve it because outcome research and data collection is expensive, whereas process metric is typically passively collected as you are providing care. So I would love to do more outcome-based research. I think to do that, we need specific funding that is tied to measuring those outcomes so that we can be sure that we're actually achieving them.
Yeah, I mean, maybe I just say the study that I mentioned to you where we saw that 4 times reduction in interruption in treatment, because there is multi-month dispensing in Nigeria, that meant that those patients had to be followed up for, almost 2 years so that you could get enough touch points to see whether you had actually made a difference in interruption in treatment or not. So that was a massive study that required significant investment to be able to come up with that kind of data point that really linked to a firm health outcome. So it requires dedicated investment for that kind of research. And I think if we think that that's important, then we need to invest in it. I will push back though and say that sometimes I feel like we set the bar so high all the time, saying that we need health outcomes data all the time, and actually major efficiency gains is a pretty good win too. And so, there are certain places where we set the bar too high. And then just in terms of the health workers and making sure that's acceptable and that, they're involved in the design. So again, for that particular example, the model was developed first. It was then exposed to health workers in, sort of a paper-based tool that they looked at. Then it was put into like a simple ComCare app, and then it was integrated into the case management app that they were using over multiple iterative steps with, health worker input. So I think that was the important thing, was just making sure that they were involved along the way, and that from the start it was clear that this was part of a tool that they had to use on a daily basis. It wasn't a separate add-on. It was integrated into the way that they needed to work.
Okay, let's go to another question.
So
Yvonne, and you can answer that one. I just want to get to more questions, and we'll get you to answer this one next.
Sure. So I'm Aditya Kulkarni. I'm a healthcare entrepreneur from India, and I have developed one technology which can early identify preterm babies to save infant deaths. I wanted to share one of my experience where public partnership has helped us design a business model which has been adopted to a certain level in government. So in India, with UNICEF's support, we ran this pilot where each pregnant woman would get fetal monitoring at a cost of $3 per patient. In government, we managed to procure it at $1 per patient. This year, I am visiting African countries in order to see partners which can help us co-develop this business model and scale it in Africa. So are there any avenues for an entrepreneur like me who has successfully demonstrated it at one geography and has some early success to come into Africa and try the same model out here? What are your thoughts?
I'll just say yes, for sure, I think. But anybody want to jump in on that one? You're almost in sales, I think, in a way. Eh? I like that. Yvonne, you got to get
Yeah, I think it's possible, and especially looking at it from an implementation science angle, that's probably where we can start it. start with. So if a model has worked in India, for example, the next bit is to come test it in, let's say, a country like Kenya. And so thinking through, number one, looking at the feasibility of implementing the model. And so we design it in an implementation science sort of concept. Look at the feasibility, some of the barriers, and facilitators influencing its implementation. Once we pass that and it's able to show, reliable results, then we can think of scale. Yeah, so it's actually possible for us to do that.
Thank you. Next question. Whoever has the mic.
Good afternoon, everyone. My name is Tahir Buhari, working with eHealth Africa, based out of Nigeria. And I just wanted to share, we just concluded the third cycle of testing a AI clinical decision support system with community health extension workers. And yes, we have seen a lot of the benefits. A lot of you have sort of mentioned better and improved diagnostic accuracy, reduced treatment errors, and all of that. But we also saw that in 33% of the LLM feedback, there was some inaccuracies. So my question is, what level of imperfection is acceptable, for scaled deployment? And who decides the safety thresholds, for these kind of considerations? Thank you.
I'm not touching that one.
I just want to say, I don't know the answer to that, but I think it's a really important question. And that's starting to think about quality assurance and quality improvement in a virtual domain is hugely important, because we already have a lot of practices around quality assurance, quality improvement in the physical health services, processes that we use in order to try to ensure quality and performance management of health workers, etc. So how does that move across now into the digital domain, and whose responsibility is that, and who is setting those thresholds? I can't tell you what the threshold should be, but I can say I do believe that we need, as a community, to decide what is an acceptable threshold, knowing that in our analog systems before, there was certainly an awful lot of inaccuracies and treatment errors, and so we can't be thinking that we're still building on what was a pretty bad base to start with. But yeah, it's a community conversation we need to have.
Rob, going to go quick on that one?
Yeah, in our study, we had about a 3% hallucination rate, given the model performance and the task that we were giving it. So to me, we need to be responsible for that. We need to set those thresholds, and that's why we need a human in the loop for the foreseeable future. There was differential acceptance of appropriate recommendations versus inappropriate recommendations by the humans, right? So humans are more likely to accept an appropriate recommendation than an inappropriate one, which is why you still need the human in the loop.
Okay, next question.
Thank you guys for the really engaging conversations. Rusita from Dalberg Data Insights. My question actually is to Rob. Rob, you and Panda Health have inspired quite a lot of funders and the ecosystem overall when we think, and including big tech, on what is possible with AI when we think about health facilities. You've tested and proven a use case or multiple use cases in the private sector space, right? In private clinics. What do you think would take to scale that in public health facilities? You already touched upon the digital bit, which is really important, but say more. What enablers should be there for us to see what you've done in private health facilities in every public health facility here in Kenya?
Yeah. By far the most important thing is digitizing all of the workflows. Because if you do that well, then the models can provide such a benefit to the frontline worker that they'll actually pull it. What I mean by that is they will ask for it and they will act on the recommendations, assuming you test the technology, test the prompts, iterate on it, build it exactly for their workflow. I'm assuming you're going to do all of those things. But if you do all of those things, it is such an obvious benefit to the frontline health worker that you will get adoption and it will be used. But digitizing is the big gap that we have.
Right, and I just want to go to Yvonne on that one, because I think that one of the benefits that Penda has is you own the platform that collects the data and you own the processes that informs the data, and that I think in public sector there's less continuity and makes it a little difficult. But Yvonne, I'm thinking of you. Does that make sense to you? Like, how would you see a model like Rob has integrating into the public system, which you work a lot with?
Yeah, and I think that's a good question, because when you talk about primary healthcare, We're also looking at the lower level facilities, the dispensaries, and probably medical centers. And this is where majority of the communities access healthcare. So I think once it's worked in, let's say, a private facility, then of course the next step is to think of how do we pilot in lower level facilities, learn from the process, and think of areas to scale. Because in terms of dynamics, if you compare private, public facilities, the differences are huge in terms of infrastructure, healthcare workers, among others. So the core is let's pilot, and let's not try to experiment. If it works, then we have opportunities to scale.
Thank you. Next question, go ahead, yeah.
Hi, good afternoon. My name is Gabriel Catan from the World Bank. I would like to return to the business model issue. In my previous job, I was leading health innovation investments in Latin America and the Caribbean at the Inter-American Development Bank. And one model that I saw that was very useful in Brazil, I know maybe probably it's not the same context, but it was the open innovation model where you have a public hospital bringing external ideas from health startups from the private sector, incubating them within the organization, testing their solutions within the organization, and then absorbing their technology and scaling up and maybe getting it out to the market. So what is the potential for open innovation in Africa? Thank you.
That's a great question. Go ahead, Joanne, yeah.
So I'll just say that in working with the Intergovernmental Working Group through Health Tech Hub Africa, we definitely see certain governments that have a real innovation orientation, and they are investing and they are trying to bridge the gap between public and private sector. And so two that I can easily call out are Ethiopia and Rwanda.
Right.
So we were very fortunate to go and tour the innovation center that's actually been created at the Ministry of Health in Ethiopia, where they have invested their own domestic resources, it's not donor funded, to create this innovation space where they now are inviting innovators to come in and work on ideas there, but they have written up very clearly what their government priorities are. 8 government priorities written on the whiteboards there, inviting innovators to come and address those and guiding that process, and then investing seed funding into some of those innovators, and importantly, giving them access to certain facilities where they can test their solutions. And you see the same in Rwanda, where they're also designating that these are certain public facilities where you can come and test your solutions. And this is seed funding that comes from the government in order to allow you to work on your solutions. And in some cases then they're still finding private sector business models, like they're still doing a B2B or a B2C business model, but they're getting the licenses and permissions from the government to work. So I think a lot of it is about that government orientation, their willingness to make those spaces. And we do see some, and then I think there's a lot of peer influence that comes from that. That's why we try to create these intergovernmental groups so that one country can share what they're doing and how successful it's been and inspire others to think about doing something similar.
Yeah, and we've seen just really founders and CEOs in the space are really encouraged. I think there's more opportunities than ever before, and people are actually making money as well through public sector engagement. It's still early, but it's happening. But your point about kind of a sandbox, an open place, that's well taken. It's not there yet, but I think that would be really valuable. One last question. We got 30 seconds, quick one, yeah?
Hi, thank you all for your insights. I'm a primary care physician and I've worked in clinical evaluation of AI in healthcare, so a great intersection, the perfect session for me. I also host the Global Perspectives on Digital Health podcast, which is what can the so-called global north learn from impacting underserved communities with tech. I hear a lot about scalability and I hear a lot about trust. And at least in my mental model, doing things that build trust and doing things equitably and making the hard decisions from a product decision-making perspective involve doing things that don't scale, i.e. actually sitting down and listening to communities and going slow to go fast. I don't feel that the donor or perhaps even the health system reimbursement or business models actually reward the people who are making the effort to do this. So for me, this is a circle, a square that needs to be circled, or vice versa. What are your thoughts on this?
Wow, 0-0 on the clock. Yvonne, you want to jump to you?
Yes, I think you raise a very critical issue, and that ties to the bit around responsible AI. and the ethics around it. And trust is very critical. So for me, I think as we come up with models, using or integrating human-centered designs as we develop them is very critical. And so using an all-inclusive model, especially at the point where you're co-designing or thinking about a solution, it's very critical that you engage the end users who are community members and the different stakeholders, so that at the point where you're creating a model, there's all, or rather in terms of inclusivity of all perspectives across the different, persons who utilize that. And eventually, if you have that factored in as you get to deploy it within communities or utilize, usually that enhances the aspect around trust. So HCD is very critical at co-design phase.
Rob, last word, not necessarily for that great question, but just
No,
last
it is
word.
for that great question, and maybe it's also my hot take for your podcast, which is even though we're at the Global Digital Health Forum, I think brick and mortar is still very central. And to your point, we can't just scale something purely digital and expect that it's going to have trust of communities and trust of individuals very quickly. I mean, Penda is expensive and slow to scale because we have to build branches and we have to wait months for thousands of people to come. And when they see us in the community every day, 24 hours a day for years, then they get that trust. But that is unfortunately slow and capital intensive.
Joanne, last little word, and then we'll wrap it up. Do you have anything?
No last word on that. Just echo what my colleagues here have said. But yeah, I think that people build trust in these AI models faster than we might think. The kind of questions that they ask in the beginning, they morph quite quickly into quite sensitive personal lines of engagement and questioning, much faster than you think, actually. So I think we might be surprised that actually the adoption can be faster than we think.
And for me, I hope you share the optimism that we're greatly inspired by the technology, but that we think it can make a tremendous impact on primary care. No one, again, has it all figured out, but certainly enough signposts are there that it's going to be a net positive, and we're excited to be part of that journey in the future. Thank you for joining, and again, we're around if you want to engage more. Thanks again.